I'm Dr. Larry Burchett, and welcome to your 5-minute weekly coronavirus update for July 24th, 2020, powered by AverPoint.com. This week we're joined by Shouvik Banerjee and Dr. Kathleen Montgomery as we review the evidence and science behind the weekly COVID cases, coronavirus and testing, and COVID in rural America. We begin, as always, with the numbers with Shouvik Banerjee. Shouvik?
The U.S. hit 4 million coronavirus cases this week. Now, in early June, we were seeing about 20,000 cases a day. That's gone up week after week to 66,000 new cases a day. Now, this week, it actually stayed flat at 66,000, but there's reasons to doubt this is an actual plateau. The CEOs of LabCorp and Quest Diagnostics came out and said, our testing capacity is full. Some patients are waiting over a week for test results. Meanwhile, the virus is spreading to rural areas where people are just too far from testing sites. Now, the big states are still the story. California, Florida, and Texas are all seeing about 10,000 cases a day and all have 10,000 patients in their hospitals. So these three states account for about half the story. Now, the big states sometimes mask the pain in small states, like Louisiana and Mississippi, where the virus is actually spreading a lot faster than it is in California. And cities sometimes mask the pain in rural America. In Texas, Hidalgo County saw so many deaths this week that the crematorium had a waiting list, and they were putting bodies in refrigerated trucks. Now, globally, the world hit 15 million coronavirus cases this week and 630,000 deaths. The hotspots remain the US, Brazil, India, Russia, and South Africa, which had long contained the virus, has now become a hotspot. And now, given we're seeing issues around testing capacity, we turn to Dr. Montgomery to discuss the science behind coronavirus testing.
Now let's compare the different types of coronavirus tests available. Right now, there are 3 types of tests: PCR, antigen, and antibody. The PCR test is the big one you need to know. It's the gold standard for diagnosing coronavirus and the test that the official case counts are based on. The PCR test works by detecting viral genes, or RNA. It is incredibly specific, meaning that a positive result is almost always a true positive. However, it is not very sensitive, and even on the best day, the test will miss about 1 in every 5 cases. Some employers require patients to have a negative test to return to work, but patients can have a positive PCR test even months after symptoms have resolved. Doctors agree that repeated PCR testing looking for a negative result should not be a requirement for returning to work. A study from Korea found that COVID patients could test positive by PCR months after diagnosis, but they found no evidence of live virus or viral transmission from these patients. This means patients are shedding the viral fragments that aren't contagious. A study from Korea found that COVID patients could test positive by PCR months after diagnosis, but they found no evidence of live virus or viral transmission from these patients. This means that the patients are most likely shedding viral fragments that aren't contagious. Next, what about antigen tests? Antigen tests detect viral proteins. The big advantage to these is the quick turnaround time. They can be performed in just a few minutes while you wait. So why aren't we using them everywhere? Well, the problem is they're even less sensitive than PCR. They require 1,000 times more virus than the PCR test, and even then, one study found that they were only 30% sensitive, meaning 70% of people who had COVID-19 had a negative test. Because of this, the WHO does not recommend using antigen tests. If they are used, a PCR test should also be performed to confirm the result. Lastly, antibody testing. This is a blood test and doesn't turn positive until 1 or 2 weeks after symptoms begin, so it's better for detecting whether a person has already had the virus. Now, the antibody test is the opposite of PCR and antigen tests in that it is sensitive but not specific. This means you can believe a negative result, but a positive result may be a false positive. So what should we expect moving forward with testing? The recent case increases have caused delays in the reporting of PCR tests, leaving some patients to wait a week or even longer for results. Scientists are working on a more sensitive antigen test, but expect PCR to continue to be the gold standard for diagnostic testing until a better antigen test is developed. Now on to you, doctor.
Today I want to talk with you about COVID and rural America. As you can see in this graph, cases in rural America have increased 2.5 times in the last month. This is non-metropolitan cities. We're talking with populations in the thousands. Why? And what's coming for the American countryside? Now, I've worked both in New York during the surge and in rural California ERs diagnosing COVID since. COVID is on the rise in rural America. As you can see in this graph, when COVID hit the big cities like New York in April, viral spread was enhanced by population density. That's this black box on the right side of this. A lot of people living in a small area, the virus easily spreads. That's the black box up there. Now that same population density, look on the other side in rural America. It benefits them. It decreases COVID risk because people live more spread out, so there's lower risk of getting the virus. But look over here on the rural. What is the big risk to them, that white dotted box? What raises risk for towns with less than 2,500 people? And I mean, it raises the roof. Age. It's an older population. Remember, most COVID deaths, over 80%, occur in people over 65 and in poor health. And rural America has more elderly than big cities, and they're in worse health, which puts these small towns at greater risk. Now, interesting, look in the same graph. For places that are slightly less rural, so over a little bit on the graph, 2,500 to 10,000, there is risk from age, but also more risk from poor health, things like heart and lung disease, cancer, but also institutions. We're talking about prisons in towns of those sizes. When you go up to 10,000 to 1 million, nursing homes carry the most risk there. Interesting, right? There aren't as many nursing homes in smaller towns or bigger cities. Another study shows essentially the same thing that we're talking about risk for rural America, which is that of age and general health is worse in smaller towns, conferring additional risk. Also, let's not forget about poverty, which increases diabetes, high blood pressure, obesity. All of those are connected to worse outcomes. Additionally, decreased willingness to follow public health recommendations, including wearing masks and social distancing, only makes rural prevention and viral spread an even greater challenge. Let's look at this from a totally different perspective. Look at the non-big city red hotspots on this map. What can we learn when we look at outbreaks? Where do they come from? Now, similar to the above data we were just reviewing, in these smaller towns we see three things: prison outbreaks, meatpacking plants, both which makes sense, right? People in close contact inside for a long period of time with limited ability to social distance. Now, the third thing is something we've also talked before about on this show: race. Note how many communities in the top 10 of this list include high numbers of Latin American, African American, or Native American populations. Again, COVID affects us disproportionately by race. Now, in addition to the above, churches and grocery markets, places where people gather appear to increase risk of spread. You can imagine the public health challenge with having one grocery store in 50 miles in rural America. Additional causes for concern: rural hospitals are closing, have fewer hospital beds and ICU beds, fewer specialty services, and lower testing and tracing capacity. All of this impacts rural America's ability to prevent and treat this disease. For Shouvik Banerjee and Dr. Kathleen Montgomery, I'm Dr. Larry Burchett. We'd like to thank you for watching our 5-minute COVID weekly update. We hope you've enjoyed it. Please share this information if you found it valuable. Check out the evidence on AverPoint.com. And as always, stay safe. We'll see you next time.